Hello, everyone. My name is Jackie Cole, and I'm a medical liaison with Baxter Healthcare supporting infusion therapies and technologies. Next slide. Welcome to Infusion Titration and Best Practices webinar with a multidisciplinary team from the Cleveland Clinic. The team is excited to share with you their organization's strategies for optimizing IV medication titration practices that align with the Joint Commission standards. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You see here a screenshot of the attendee interface, and you should see something that looks like this on your computer screen. You will have the opportunity to submit questions to today's presenters by typing your questions into the Q&A window. To activate the Q&A window, you will need to click on the Q&A icon at the top of the webinar window. The Q&A window will open and you may type your question in the field labeled Ask Your Question here. You may send in your questions at any time during the presentation, and we will collect these and address them during the live Q&A session at the end of today's presentation. At the conclusion of the webinar, you will see a QR code for a brief survey. Please take a few minutes to complete the survey. This will help inform us on topics for future webinars. Our goal today is to interact with you, and we will be using the platform Slido for polling questions and knowledge checks. So when the polling question or knowledge check pops up on your screen, please scan the QR code to respond to them. The speakers are compensated by Baxter for this presentation and have no other financial or other non-financial conflicts of interest to disclose. And now I'd like to turn the presentation over to Dr. Bulgar-Grozav to kick us off.
Thank you. Good afternoon, everyone. Can you hear me well?
Yes, we can hear you.
Okay, great. Thank you. Good afternoon, everyone. My name is Alina Bulgar-Grozav. I am the Manager, Medication Safety Services with Pharmacy Department at Cleveland Clinic. Before going into the details around our journey for titration orders, I would like to start off with telling you a little bit about Cleveland Clinic. Next slide, please. So our Cleveland Clinic health system is comprised of more than 20 hospitals and clinics in 4 different countries. We have 14 hospitals and numerous clinics in Northeast Ohio. We also have 5 hospitals and clinics in Southeast Florida. We have 1 clinic in Las Vegas, Nevada, as well as 1 clinic in Toronto, Canada. And we also have presence internationally with 2 hospitals, 1 hospital in London, England, and another hospital in Abu Dhabi, United Arab Emirates. We have more than 6,600 beds with 1,400 just here at main campus. All of the presenters today, including myself, we all work at main campus, our largest hospital. However, we all have health system responsibilities. As far as caregivers, Cleveland Clinic health system has more than 80,000 caregivers worldwide. And we are very proud to state that we have been ranked number 2 hospital in the world by Newsweek. Next slide, please. So for today's presentation, we hope to give you an insight into Cleveland Clinic's process to standardize titration practices and our strategies that we've implemented, such as block charting and titration audits to align with the Joint Commission standards. We also hope to walk you through our journey on how titration orders and parameters were built into electronic health record. And then lastly, we hope to also give you an insight and discuss with you how smart pumps support consistent and compliant administration practices for these titration orders. Next slide, please. So what are titration orders? Joint Commission defines titration orders as those in which the medication dose is either progressively increased or decreased in response to the patient's status. The most important aspect for any medication order, but in particular for titration order, is safe administration. Safe administration consists of consistent administration practices among nurses or other practitioners. Also, it consists of ensuring that the patient response is not only achieved, but also sustained. That our nurses are not placed in a position of making dosing or administration decisions that might conflict with their scope of practice. And lastly, equally important is documentation. And documentation should reflect accurately all of the order changes, the patient's assessment, as well as the patient's response. Next slide, please. So let's start off with our first case. For our case, we have a patient, Mrs. Smith, that arrived to the ICU after ongoing open heart surgery. She is actually on a norepinephrine order, titration order for hypertension that was entered into the electronic health record, as you can see in the screenshot from the slide. So my first question to you is this titration order compliant? Next slide, please. If you could start entering your answer, that would be great. So the question is, once again, is this titration order compliant? We'll wait a few more seconds. I see we kind of have a consensus that the answer is a no. 100% of you answered no, with just a few 4% stating a yes. And the answer is no, the titration order is not compliant. Next slide, please. So my next question, if not compliant, what is missing? And I don't know if you had enough time to review the order, but that is my next question to all of you. And
would it be helpful to bring back the order? Might be a little helpful to bring back the order,
yeah,
just so that they can see it.
Wow. And I don't know if we can do that, but I see an answer. Time frame for titration, increments to titrate, and time frame, up and down increments, time frame, missing how much to titrate by. So I see some of the answers coming through: amount and dose to titrate each time, starting rate, starting dose, objective goal, amount to titrate by. And we'll go back to the case study and the actual order. So again, the order is norepinephrine, 32 milligrams in D5W to 50, the dose 0.5 to 200 mics per minute, titrate to a mean arterial pressure of 65, starting dose 5, and that is all for this order. So going back to that second question, keep those answers in mind. We'll come back to your answers, to these answers in a few minutes to discuss some of these answers. Next slide, please. So wanted to give you a little bit of background on our journey around titration orders. Our journey started a few years ago, 2016, during one of our main campus triennial Joint Commission survey. During that survey, we were cited for our titration orders. At that time, we were found out of compliance when it comes to the actual orders. They were considered to be incomplete. And then we were also found out of compliance for nursing documentation. So we were not alone at that time. This is an area of focus for Joint Commission during the hospital accreditation surveys, and it's been one of the top medication management findings for the past would say at least 8 to 10 years. Once again, we are not alone in this journey, but wanted to, for today's presentation, to walk you through what we have done to address some of these findings and to optimize our titration orders. Next slide, please. So when it comes to what is required for a titration order, these are the 5 elements that every order should have: a start dose or a range for the infusion, the dose for the incremental adjustments, the frequency for these incremental adjustments, the maximum dose or rate for the infusion, and then lastly, an objective measurable clinical endpoint such as RASS, pain score, or blood pressure, systolic blood pressure, mean arterial pressure. So every titration order should have all of these 5 elements present in order for a safe administration of the medication order. Next slide, please. So going back to our case study, you are correct. There are 2 elements that are missing. One is the dose increment for adjustments, whether it's increasing or decreasing the dose and dose increments, and then the frequency for the dose increments, like the majority of you already stated. So now I would like to turn it over to Alyssa for her to walk you through our journey in optimizing titration orders in the electronic health record. Alyssa?
Thanks, Alina. My name's Alyssa. I'm one of the clinical informatics pharmacists on the Willow team at Cleveland Clinic. In my previous life, I was actually a medical ICU pharmacist, also at main campus at Cleveland Clinic. So this hit pretty hard to home when we started discussing this. So on this slide, you can see the changes that we made as a result of those missing elements that Alina just discussed that were identified back in 2015, 2016. And you can see that we now have a starting dose or range, that 0.6 to 10 mics per minute. The dose for adjustments, the 0.5 to 5 mics per minute, and the frequency, which is every 1 to 2 minutes, as well as the max dose and rate of infusion and objective clinical endpoint, which are still included here. The second piece of this screenshot at the bottom right shows how the content displays to the provider when they're entering the order, as well as some additional restart parameters that we added with another round of updates in 2019. If you can move to the next slide. So after the initial updates to these admin instructions, we continued performing internal audits and unfortunately noticed we were still not consistently fulfilling all the elements that were required by Joint Commission. Because administration instructions are free text, we're not able to require elements within that field that can't be deleted by providers. Another challenge we encountered with admin instructions was the difficulty of changing an existing order to be titratable if it was placed initially as not titratable. That would require the provider to completely discontinue the old order and then place a new one from scratch to ensure all of those titration parameters were included. And we found multiple instances within that audit where providers were deleting certain required elements, leading us to pursue using order questions to ensure required elements were not deleted. So the next few slides will show some screenshots of what these order questions look like implemented at Cleveland Clinic within the MAR and order entry. So if you can advance to the next slide. This is a screenshot of the order questions in the MAR. The middle section is where our order questions appear. And again, you can see those required elements displayed slightly differently than how they did in the admin instructions, but it includes all of the pieces that are required by the Joint Commission, including, you see the starting dose, they pick whether it's titratable, the goal endpoint, as well as the max dose rate and objective clinical endpoints. So moving on to the next slide, this is another screenshot of the same order questions, but after the nurse scans the medication, this is the MAR that populates. The order questions now appear on the left-hand side. So same, everything still appears. So it's nice to reference for the nurse. So if you can advance to the next slide, we can see what these look like on order entry. So this is what appears for the provider when they're placing the order. they're initially required to select between titrate and do not titrate. You can see in the middle of the screen. And if they select titrate, you can see these cascading questions that are required or defaulted based on where it's ordered from. The majority of this content cannot be deleted. You can see that they can edit the text within the dose and frequency for adjustments. But if they delete all of the text, there will be a hard stop. In addition, they can pick specify range, but we do require a lower and upper limit for those clinical endpoints. Example here is the MAP goal, and you can see that they have to type in both a lower and upper limit, and that is required. If you advance to the next slide, there's another screenshot of order entry. So if they select another target parameter, so in this case, systolic blood pressure, this one only has the specify range option. There are no other goal buttons like we saw for the MAP where it had like 60 to 65, 65 to 70. This is because at the time that they implemented this, providers were unable to come to a consensus as to what the buttons should be. So we had to basically require just this specify range. And then the last screenshot on the right of this slide is if the provider clicks on do not titrate, you can see the cascaded order questions no longer appear. And that's how they can click between do not titrate and titrate, making it easier for them to modify these kinds of orders within the same screen. If you can move to the next slide. I'm going to briefly touch on implementation. So we began with a smaller subset of medications, which included vasoactives and a couple of blood pressure lowering infusions. All of the order question options were approved and vetted through the various provider, pharmacy, and nursing committees to ensure they were appropriate. There was extensive analysis of defaults and things that we had set within our order sets and other panels to accommodate for existing clinical content. In total, it took about 6 to 8 months from start to finish for that first group of medications, which includes analysis as well as committee approval. And if you can advance to the next slide, I want to go through some of the challenges that we did encounter with our implementation of order questions and kind of why we are still kind of have only implemented the first group. So the first challenge appeared within the anesthesia module of our EHR, where we identified an issue if a provider documents on a titratable infusion intra-procedurally and then attempts to continue the same order in recovery, the order questions don't display. So that causes issues for our PACU nurses who are trying to titrate but have no instructions on how to do so. And the next piece I would say that was a huge challenge was that the majority of our timeline was spent with evaluating existing order sets and other content that already existed to make updates to those defaults to make sure our order questions fit those parameters, or we updated those order sets or clinical content to match what is appropriate for our patients from a regulatory perspective and makes it safe for nurses to administer. So it required a lot of clinical subject matter experts to make decisions on how to update that existing information. The other pain point was user created content, whether on preference lists or user versions of order sets where providers had defaulted information in their admin instructions, which caused discrepancies when we first implemented the order questions because there was often conflicting information. So we had to go through and wipe that information, and users had to go back through and re-default their content using the new order questions. And although order questions help make it easier to toggle between titrate and do not titrate, providers were not updating the dose field consistently to be ranged or not ranged because these are two separate discrete fields. The order questions are not really connected to the dose buttons, so there isn't a way to require a range be associated with a certain order questions. So that makes it still a little bit challenging for pharmacists on verification. Finally, the order questions have not yet been implemented for pediatric patients. And since we have shared medication files, we had to separate out some of that content for pediatrics so they didn't see those order questions. And because we're still waiting on development from our EHR, for the anesthesia issue, we have temporarily paused implementation of order questions to additional medications at this time, but at least we now have a roadmap on how we would go through and implement this in the future. As I'm sure you all are aware, med orders are only a small piece of infusion titration. So now I'm going to turn it over to Myra, who will be describing our approach for nursing bedside practice and documentation.
Well, thanks so much, Alyssa. My name is Myra King, and I'm a clinical nurse specialist manager for our clinical nurse specialists in our ICUs. I also work clinically in our CVICU and was part of an interdisciplinary team that really implemented this work throughout our enterprise. So next slide, please. So as you know, as Alyssa and Alina discussed, we did a lot of work with optimizing our orders. As we were implementing strategies to standardize our titration practices, we really needed to prioritize how this was going to impact the point of care. You know, nurses at the bedside, what was the implication to nursing practice? So going back to the case study, this was a typical scenario for our nurses caring for patients during that time. This is Nurse Nancy. She's a new graduate, started in our CVICU 6 months ago, and she's caring for Mrs. Smith in addition to another critically ill patient. She attended the education on documentation that we provided, in which we highlighted that documentation must reflect dose adjustments and the clinical endpoint with each titration. Typical response that we were getting, Nancy states, "I'm feeling overwhelmed. I can't keep up." And so we know that we needed to put some tools in place to assist our clinical nurses at the point of care. Next slide, please. And so, you know, as we early on, we had several documentation challenges, and we continue to monitor those challenges throughout implementation. We were seeing that the documented dose adjustments were not always matching the prescribed dose adjustments, specifically as amounts to amount and frequency. So perhaps the norepinephrine was being titrated at a higher dose or frequency than what was prescribed, or at least that is what was being reflected in the documentation. We saw that the documented endpoint was not at goal, and no changes were being made in doses. Or perhaps the endpoint was at goal, but additional changes were not being made in the doses. And so essentially, it was difficult to follow the patient's story as it related to titration of those medications. We were also seeing that there was missing documentation of the endpoint with each titration. So if you look at the example on the screen there, here's Diprovan. The Diprovan is being titrated based on the patient's RAS, which is -1, is typically a goal for our patients in our orders. But when you look at subsequent documentation, the nurse titrates up to 55 mics per kilo per minute, then to 60, but there's not an accompanying endpoint to justify or explain why those titrations happened. So again, the story not being clear. Next slide, please. Again, what can we do to optimize getting the story of each titration? So, as with always, we started with robust education, right? We wanted to make sure that there was clear awareness and understanding of what the required elements were. We took a hands-on approach. So in this example here, we would provide a case study, and then we would ask nurses to fill in the blanks. So in this case study, this patient is hypotensive, and they're started on norepinephrine, and here is the accompanying goal map and what the maps were. So complete how you would document titration, how you would titrate based on the patient's mean arterial pressures. Remember, documentation must describe your actions and tell the story. This was on paper at first, and so we would go around and do the education. We eventually pulled up test patients in our electronic health record, had them complete it, and then we put these case studies in a module that nurses are now required to complete upon hire as well as annually. Next slide, please. We developed a pocket guide. And so on this pocket card, it was available at the bedside, so nurses could reference it as they were completing their titrations. Essentially, it was a checklist, and it reminded nurses that our best practice, our policy states that you titrate at the lowest dose and the slowest frequency. We gave examples of clinical endpoints and then a reminder of the requirements for each titration as they were starting and titrating medications. We gave examples as to when it may not be appropriate for nurses to titrate low and slow. So there is this disclaimer that exists within our policies. If the patient's condition necessitates a higher dose or faster titration, but remains within the ordered range, here are some of those scenarios. The progress towards meeting the ordered endpoint is unsuccessful using low and slow. There's a rapid deterioration from baseline, or that the endpoint is significantly above or below the ordered goal range. There also may be signs and symptoms of acute end organ damage. Again, really needs to be able to tell a story as to why that you went up higher than the lowest dose or faster than the slowest frequency. The rest of the pocket card, again, just highlights that each titration needs to have an accompanying endpoint. Next slide, please. Having that pocket card at the bedside was helpful that nurses could reference as needed. However, we also wanted to utilize our electronic health record to help us in providing tools for our nurses. So we were grateful to be able to collaborate with our pharmacy informatics team in some of these endeavors. You can see most of our nurses will titrate in their flow sheets. And we had it on the side panel where the order was available. However, you can see that that order is at the bottom of the side panel. So it's really hard, particularly as nurses were busy, to really look at the order and know what the requirements were. And so what we did was we asked our pharmacy informatics to make some adjustments. If you go to the next slide, I have an example of what that looks like. We had them put the order up on the side panel so that as nurses are documenting, it's easily accessible and can be referenced. Again, those admin instructions really are visible. So it lets you know what's the clinical endpoint, what's the frequency and the dose at which you are to document, and then when is it appropriate to notify the provider. And that side panel would populate as the nurse clicked on that particular row for documentation. Next slide, please. We wanted to make sure that our policies were easily accessible to nurses as they were titrating as well. We do have an online system that houses our policies, but we really thought that would be helpful to make relevant policies easily accessible right on the MAR. So we added a link to our policy so that nurses can pull it up and reference it as they are titrating if they had questions in terms of what the requirements were. Again, that was also a helpful tool. Next slide, please. In terms of when nurses would document in the MAR, we also wanted to have a process by which nurses were reminded to document the clinical endpoint. And so we asked that the clinical endpoint, the relevant clinical endpoint, appear in the MAR with a reminder for a recommendation. So as you are documenting your dose change, that clinical endpoint would be visible and a reminder would pop up stating, hey, remember to document your clinical endpoint. If the nurse had previously documented on their RAS in this example, then the last filed RAS would be pulled into the MAR, and the nurses could select, yes, I want to use that RAS, or no, I want to document a new RAS to demonstrate and justify why that dose change is occurring. Next slide, please. We developed an audit process to see how are we doing. We're doing a lot of work to provide tools for our nurses. How well are we doing? So we started with looking at our orders, and you can see in the yellow there questions as it relates to all of the required parameters for orders being present. And we found that the work that Alina and Alyssa described earlier in this presentation worked very well. Those elements defaulted, the order questions were being utilized, providers were utilizing them. And so we had really good compliance with our orders being compliant. Where we found opportunities continue to be in the medication titration requirements. And so that's in the blue section, and there were questions in regards to this order starting range being followed, were meds being titrated at the appropriate dose and frequency, etc. And so if you go to the next slide, I do have some examples. This is an example unit, so it doesn't reflect our actual compliance, but it reflects what we were seeing at that time. And this, again, an example unit. So you can see that for meds started within the ordered starting range, we did really well with nurses being compliant with starting this at the appropriate dose, as well as or continuing if the patient was coming from a procedural or OR area. We also did well with meds being titrated at the ordered dose and frequency. However, by far, our greatest opportunity continued to be that endpoint parameter was documented at the time of each titration, and as well as staying within the endpoint parameter goal. And if that endpoint parameter goal was exceeded, was the medication titration done in response to being outside of the goal, as well as that endpoint being reassessed. So we still had those opportunities that existed despite our efforts in providing tools to our nurses. Next slide, please. So we came back to the drawing board, and we were reminded of our required nursing documentations per Joint Commission, as well as in our policy. It states that our documentation must accurately reflect dose adjustments in the patient's response. When we looked at our internal audits over 2 years, we were only compliant about 50 to 62% of the time. So we still had significant opportunities as it relates to our compliance. We decided to do a deeper dive. When are these fallouts occurring? What are the situations in which these fallouts are occurring? Let's talk to our nurses. Let's get some feedback and see where our opportunities exist. And what we found as we did our deeper dives was that the fallouts primarily were occurring during urgent events when nurses were busy at the bedside caring for a patient who was clinically deteriorating. It was just a challenge for them to obviously be able to be at the computer and document and care for the patient. So the leaders, as well as clinical nurses, came together and started to brainstorm some ideas. And we came up with this idea of what if we could just document in a note during an urgent event. And so I remember being in a conference room, we kind of drafted up a note, we talked about it, we circulated it, and then we proceeded with that. So if you go to the next slide. Once we had a note template that we drafted, we consulted with Joint Commission, and that was really helpful. We asked for feedback on the note, and they were really helpful. The representative was helpful in providing guidance to us and gave an approval for us to pilot this note. We originally called it a medication note template. Now it is called block charting. So we piloted that note template in all of our ICUs on main campus between June 2019 and September 2019. And the pilot went very well. Nurses were appreciative of the opportunity to have an option to document in this format so that they can focus on caring for the patient. However, in September 2019, we had a Joint Commission visit, and it was during that time that it was noted that we needed to ensure during the urgent event that the orders or the directions that were given during that by the provider present was actually reflected in our electronic health record. And so we expanded our note to include a co-signature feature, which I'll discuss in a couple slides later. That was the missing element that we needed for this note to be successful at our organization. In September 2020, the Joint Commission revised the medication management chapter to include block charting for nationwide adoption. In March 2021, we rolled out that block charting throughout our health system. And in August 2022, we had a Joint Commission visit on our main campus, and there were no findings related to medication titration or block charting. In fact, the surveyors complimented our process during their ending session. So this was really a celebratory moment for us, as we had been dealing with this challenge for several years, a lot of work, and it was great to see the progress that we had made in this space. So again, time for celebration. Next slide, please. For those of you who may not be familiar with the block charting definition by Joint Commission, we thought that we would provide it to you. So how the Joint Commission defines block charting, it is that documentation method that can be used when rapid titration is needed during urgent emergent events. It cannot exceed 4 hours, and if the episode exceeds 4 hours, then another note is required to be started during that time. Next slide, please. So this is an example of our current block chart note. I'll draw your attention to the left side of the screen. And as you can see, we still call it our medication titration urgent event note. There is a narrative that's pre-populated in the template when the nurse brings it up that specifically just states that this patient's having an urgent clinical event requiring nursing or in presence at the bedside, multiple vasoactive medications titrated per physician orders. And then there's an area for nurses to document any additional interventions that are happening during that event. In the middle of the page, there's this question then that the nurse has to answer. Did you receive orders or directions outside of the MAR orders? Nurses can click on that link and go to the orders just as a reminder of what those orders were. In this particular case on the left side of the screen, the nurse says, yes, there was a provider there. I got orders that weren't on the MAR. And so they would then complete their documentation and then select the provider that was present during the event. That note is then routed to the provider for co-signature, and that provider then co-signs it, and that is the authenticated order. Much like in a code situation, when those orders are, the provider signs the code sheet, and that becomes the authenticated order. On the right side of the screen, same urgent event. However, in the green box, there weren't orders or directions given during the urgent event that were outside of the MAR. So the nurse would just simply complete the note and sign it, and it would be in the electronic health record. Next slide, please. This is just an example of our medication portion of the block chart. And this is a close-up of what it currently looks like. You can see all the medications that's pre-populated, and nurses are directed to document based on what is required. So nitroglycerin at the top of the screen there is started at a specific dose. It was titrated to a max dose, and then it was infusing at a particular dose at the end of the event for the reason for titration, that clinical endpoint. If the medication is still infusing after the event, then the provider is required to place another order. Next slide, please. This is just a summary of what I just described in terms of when a co-signature is needed and when it is not. All providers can co-sign a note, so even our advanced practice providers can co-sign a note. That note should be signed as soon as possible after the event, but there is a maximum of 7 days in which it needs to be signed to be compliant. Next slide, please. We also, of course, had an auditing process for block charting. Alina really was great at leading this initiative. And so we would look at the block chart notes, and we would audit for whether or not the co-signature was required. Was it routed? Was it co-signed within that 7 days? And did the note itself have the content? Did it meet regulatory requirements in terms of the content of the note? Next slide, please. We also wanted to provide tools for our nurse managers. And so we developed a nurse manager dashboard. And in that dashboard, nurse managers can pull this up at any time in real time. They can see the number of block chart notes that are present on their units. They'll see if the order had been routed, and if so, if that provider co-signed it. They'll see the number of notes that were co-signed, and they can actually click on it and get to the actual note and review the note in real time so that they can mitigate any opportunities or challenges with the clinical nurse or the provider in real time. So we did a lot of work as it relates to assisting nurses at the bedside to ensure that we can optimize and standardize our medication titration practices. But we also knew that we needed to optimize our smart pump technology to assist in providing safe care for our patients. So I will turn it over to Silvana to lead that discussion in regards to the work we did with our smart pump technology. Next slide, please. Silvana?
Hello, thank you, Myra. My name is Silvana Balliu, and I'm the coordinator of pharmacy services with focus on smart pumps. I'm a member of the pharmacy informatics team. So the smart pump data and the information received from the smart pump devices often reveal opportunities. We consistently review the smart pump reports and events to identify opportunities for optimization and standardization. So the impact of the standardization extends beyond the infusion devices and impacts the EHR and other applications as well. As discussed so far, titration practices can be very complex, and it becomes even more challenging if there are several options for dosing a medication. So standardization of dosing unit has been part of the smart pump initiatives, the implementation and maintenance phase, to find opportunities to minimize unnecessary and unwanted variances in practice. So I'm sharing here just a couple of examples of how we standardize the dosing unit, but there are more medications. So for both of these medications, we transition from 3 dosing units to minimize the incorrect programming. So on the left, you can see what we initially had, the options to dose propofol and vasopressin, and then how we standardize from those 3 options to just 1. Next slide, please. So another standardization effort was the bolus from bag practice, because of many titratable medications required the bolus dose administration. We worked on this project with an interdisciplinary team that included providers, nursing, and pharmacy caregivers. Previously, there was no standardized process for the bolus administration. And bolus dose were sometimes administered using a separate vial or product, and other times by bolusing from the bag, which was a questionable practice initially, just because the way how it was done, the rate of the continuous infusion was titrated up, and it involved manual calculation and estimation of the dose, the time, and the stop time as well. So then with the introduction of the bolus option on the smart pumps and the implementation of appropriate guardrails, bolus from bag has evolved into a safe and efficient administration practice. We started our standardization process with a list of clinically reasonable medications for administering a bolus dose during the continuous infusion. And we broke them down into 2 categories. So the first one was for medications with options to administer the bolus dose from a separate vial or product, or bolus from bag. For instance, the clinician needs to administer a bolus dose for fentanyl, and the only line available is the epinephrine that is running. If you administer the bolus dose, the fentanyl bolus dose rapidly, will also push the epinephrine at the same rate. So we limit the concurrent administration of the bolus dose with IV fluids only. So if there was no other line to administer the bolus from bag medication by itself, then the vial and separate practice was the only option to administer the bolus dose. So again, this was done to support every patient scenario. So if the patient had no IV lines, to minimize the risk of rapid administration of any other medication running concurrently with the bolus med, we limit that to the fluids only. However, there are some exceptions to this rule, and the exception was the insulin. So the concentration of the insulin infusion is 1 unit per ml versus 100 units per ml for the vial. So to minimize the risk of the wrong bolus dose, and then also the risk of incorrect concentration mix-up. For this medication, for insulin, the only way to administer the bolus dose is the bolus from bag. Because of the introduction of this practice, our anesthesia team actually removed the vial for any patients that had a continuous infusion running. That was the only way for them to administer the bolus dose as well. So how and why we started this? So often the bolus dose was not documented, and when we discussed it further with our providers, their feedback was that was challenging for them to find the orders in EHR. Based on that feedback, we created the order panels to facilitate the order entries and documentation for both the bolus dose and the continuous infusion by keeping them together. The bolus from bag requires barcode scanning, just like any other medication. And two options appear on the screen for a clinician to choose from when the infusion bag is scanned: the bolus dose and the continuous infusion. So regarding the guidelines that we have in place for any medication with a bolus from bag option, based on an ISMP study done in Canada, the bolus from bag practice is considered safe as long as there are hard limits in place for the continuous infusion and the bolus dose to minimize inappropriate and incorrect programming of the bolus dose. So I say inappropriate because this eliminates the risk of titrating the continuous infusion dose to administer the bolus, and any incorrect programming of the bolus dose, considering that the doses, the bolus doses in general are pretty higher. I mean, they are higher compared to the continuous infusion. Education was provided to nursing, pharmacy, and physician teams. Next slide, please. This is just a screenshot of the EHR record for the fentanyl infusion with a bolus dose administration. So as you can see, there is an option to bolus from bag and another order to use the fentanyl injection by itself. The bolus from bag order has instructions for administering the bolus dose as a bolus from bag option if the fentanyl infusion is the only medication running through the line, with the exception of the IV fluids that I mentioned. Next slide, please. So here on the screen, you see a MAR screenshot of the norepinephrine with a concentration of 32 milligram into 50. And the starting dose is 0.5 mics per minute, which results to a rate of 0.23 ml per hour. Considering the minimum rate supported by the pump, this rate is 0.5 ml per hour. Can the starting dose of 0.5 mics per minute be administered on the smart pumps? And that will be the question coming up on the next slide. Correct, yes. That rate is below the minimum rate supported by the pump, so it cannot be administered on the pump. Next slide, please. So instead of our clinicians trying to figure out the starting dose for each medication, we changed the orders in our EHR with the starting dose that was supported by the pump. So with a dose that was above the minimum rate that was supported by the pump. This minimized the alert fatigue overall on administration. Next slide, please. So continuing with that topic to minimize the alert fatigue in administration, we removed the lower self-limit for many of the titratable drips. Here I have listed the vasoactives medications. So we removed the lower self-limits since the patients are being monitored anytime that these medications are administered. So this effort, along with consistent smart pump data review and with the overall goal to lower the alerts, the unnecessary alerts, and improve the interactions with pumps, decrease alert fatigue, our overall percentage of the alerts right now is 6% of the infusions. And it used to be 20% when we initially started using the smart pumps. Next slide, please. So how can we make the administration practice safer for the titratable medications? So I have two areas to focus here. The delivery bag standardization. What do I mean by this? Let's say you have a propofol to administer and incorrectly that is programmed as a secondary, or could be programmed as the primary, but when the connection is done, this inadvertently is connected as a secondary infusion. So just to minimize all those errors, we restricted the use of the titratable medications to only be programmed as a primary infusion without an option to have a secondary running concurrently with that. The other areas for us to focus on to improve overall the safety of the administration practice is the implementation of hard limits. So I have a few examples here, but this is a consistent process. So we consistently review the data with the goal to add hard limits to the medications that do not have anything, and also look into the ones that already do have something in place to make sure that that is meaningful and relevant to our practice. Next slide, please. So keys to success, just wanted to stop here for a second and just say kudos, especially to Myra that led the nursing efforts and Alina for leading the pharmacy efforts to standardize the practice for our titratable medications. So the keys here, we have highlighted the interdisciplinary approach. This was key to our successes. The leadership, support, nursing involvement, providers, pharmacy. A lot of work was done by nursing and pharmacy informatics, communication and education. So Myra mentioned the huddles, the online modules, webinars, handouts, pocket cards, and of course, continuous assessment process is essential. This includes rounding, case studies, EPIC reports, audit forms, share results, and all this were essential for our success. Next slide, please. So going back to our case study, so orders for Ms. Smith have all the required elements. Medications are titrated for orders and physiological response. Block chart note is used for urgent situations, allowing Nurse Nancy to prioritize being at the bedside. Documentation reflects dose adjustment and clinical endpoint. Smart pump technology supports keeping Ms. Smith safe during her stay. Next slide, please. So the key takeaways for the titration practices, interdisciplinary collaborative approach is necessary to standardize the practices. Optimizing the EHR tools and smart pump technology are crucial strategies for supporting a safer practice. And last but not least, patient safety and quality of care during titration remains a healthcare priority. And the last slide has our contact information. Thank you for your time today.
Well, thank you, team, for breaking down a very complex practice and showing us ways that you were able to support your nurses in safe and effective titration therapies. We do have a number of questions, and there is some discussion between the attendees in the chat. And so I am going to bring forth some of the questions between the chat and the Q&A. One of the themes that seems to have several questions around is dose ranges. And so the first question, and this is probably to be answered by Alina and Myra, is should your dose range have been as low as 0 mics per minute, and I think that was with your first example, so that the nurse is able to titrate off completely?
Myra, I don't know if you want to take this one from a nursing perspective.
So, we really wanted to make sure that the nurses were getting the orders that were necessary for the titration. So, obviously, to my knowledge, there's not a regulatory requirement that there's an order for it to be off. There's then a required order for it to be on and being titrated based on the patient's physiologic response. And clearly, if the patient no longer needs it, then we would titrate it to off. So certainly, Alina, I don't know from a regulatory standpoint if you've heard anything different, but that has not been something that has historically been a requirement in our orders.
And you are correct, Myra. That has not been a requirement for our orders.
Okay, another question about dose ranges. How does the RN decide whether the starting dose is 0.6 or 10? And I know that question was posed before you talked about your pocket cards. You may have addressed that later, but let's touch base on that again.
Sure. Yeah. So thank you so much. It is a great question. Our mantra is, and which aligns with our policy, is that the nurse starts at 0.6. The nurse starts at the lowest dose and the slowest frequency. However, we know that we have very complex patients. There may be a need for the dose to be higher or to be even a faster frequency, as long as the nurse kind of stays within that range and can speak to the rationale for needing to adjust it based on the patient's physiologic response. That would be reflected in the documentation of the clinical endpoint and should help with telling that story. So the answer is low and slow unless the patient condition necessitates otherwise, utilizing the patient's physiological responses as our kind of guiding post, if you will.
Thank you, Myra. This question, I think, is in regards to when you showed on your screen when the parameters of when a note needs to be signed. And the question is, why is the note signed if doing the orders? I think the interpretation there was if the nurse was following the orders, why did that note need to be signed in addition to if she was dosing outside of the ordered parameters?
Yes. And so if you kind of think about what happens during an actual code situation where orders are given by the provider is there directing interventions to achieve hemodynamic stability, then we document what those orders are, and then the provider signs it, and that becomes the authenticated order. There's no need for the provider to go back in and write those orders in a code situation. So we needed that similar process to urgent events when we're trying to prevent the code from occurring, so that those directions that are given during those urgent events are documented in the clinical note, and then the provider signs it, that becomes the authenticated order. There's no need for additional orders to be in place unless there are continuing interventions after the event, such as a medication continuing after the event. The provider would then need to put that order in.
So it sounds like similar to what we used to call protocols and the initiation of protocols. The order starts in time of the urgent situation as the patient meets the predetermined parameters. So you talked a lot about the education of your nurses and how important it is to have very thorough education up front. How about your providers? How did you educate them, and was there any pushback from your providers with this as you continued on your journey?
That's a great question. I can start. I don't know if others would like to chime in, but we actually have providers on our interdisciplinary team throughout this process. And so we did have provider representation who they were responsible for providing the education and communicating to our providers these changes, as well as making sure that their input was valued in the changes that were occurring. So we had a module for providers that was developed that they could watch. We also had handout and then in several meetings to communicate this to our providers. But I think it's really important that you have those providers present as at the beginning of the change process so that they can take ownership and really know the best way to communicate out to other providers. Good question.
Thank you. Sometimes there's not always a great information out there about appropriate starting and maximum doses as patients may individually respond differently to the titrations. So how did you work as a team to determine what those dose ranges were and what the starting and maximum doses were?
I will start off with answering this question, and I don't know, Myra, if you want to add anything else. So when we started our journey back in 2016, once again, we had a multidisciplinary team, just like Myra mentioned. So our journey started with, having pharmacy representation, nursing representation, but as well as providers. And we requested input from all, and we've worked on multiple different versions of what our parameters will be, what our ranges will be, again with input from this multidisciplinary team.
Thank you. And Alina, you mentioned at the beginning of the presentation all of your different locations across the world. So are all of your locations using the same process for titrations?
All of our United States locations, ICU locations, share the same medication order files in our electronic medical record. And yes, everyone was educated as far as the expectations around titration orders. So once again, all of the United States locations.
Okay, great. Did you happen to say that different order sets could be built with unique defaults in titration parameters and clinical endpoints?
Yes, we can set defaults within different order sets. So if something's appropriate to be defaulted within like our enterprise sepsis order set, we were able to default, those map goals for that order set. So the provider doesn't have to go through and click every single time.
And sort of related to that, regarding the struggles with implementing order questions into the anesthesia model and intra-op orders, is it possible to trigger a reorder once the patient transfers to populate appropriate order questions? Also, could you repeat how you are currently managing this practice?
The workaround that Epic gave us was for providers to use the manage orders option instead of using the intra-op like anesthesia workflows that they're typically using, which is not obviously a great workaround. And we have given them some pushback on that because that's really not within their workflows. And you're kind of telling them to do something that's not working within the EHR anymore in a way, because they're told to work within the procedural workflow. So unfortunately, not a great answer, but we've been told that they should just use manage orders instead of doing the procedural workflows.
Thanks, Alyssa. A lot of times patients are on more than one medication for the same indication in these type of situations, and they're both being titrated. So how do you handle titration infusions when you have the same physiological endpoint to stay compliant with therapeutic duplication? And in this example, the person is asking, suppose you have both propofol and dexmedetomidine for a RAS with a goal of 0 to -1.
So I can kind of start with that question. That was definitely something that we dealt with and early in our journey. And so we are able to follow the guidance from Joint Commissioners regards to multimodal therapy of titrated medications. So if they're on multiple pressors for blood pressure, it is a requirement that the clinical endpoint goal is the same for each one of those medications. And then the nurse would titrate based on the patient's response. So if the patient is responding to norepinephrine during that titration, and that is the medication, of course, always having conversation with providers and staying within the orders, and that may be the medication that is chosen to kind of titrate and see how the patient responds. And then they can look at, say they're on vasopressor as well, then they would, can titrate that based on the patient's physiologic response. So we do allow for it, but it's important that that clinical endpoint goal is the same for each of the medications that are ordered, and the decision that is the nurses are trained in making that decision based on the patient's physiologic response.
Okay, thank you. Now, I know you don't have interoperability at this time, although it's certainly on your radar and you are thinking about it. So this question wants to know if anesthesia care areas will be in scope for interoperability for you.
We would like to, but at this time we haven't discussed it with our providers, and when we get closer to the interop, we'll just outline the in-scope and out-of-scope areas.
Perfect. Thank you, Silvana. As you mentioned, a lot of times the titration orders and parameters change because of the continually changing status of the patient. And so this person is asking about how you deal with the changes in parameters. So at their institution, they built titration infusions with order questions. However, if a provider changes the parameters in the order questions, this results in a new order to pharmacy. So how did you get around that?
We actually had, we have a lot of premixes for these medications, so that helps a lot with barcode scanning because they can scan interchangeably. Currently, though, we actually, with the latest EPIC upgrade, EHR upgrade, sorry, that came in, we were able to turn on what's called live editable order questions. So anytime they modify the order, it does not create a new order number. And that's kind of been a really nice feature because it doesn't crowd the MAR as much if the provider is modifying those order questions and changing those goal parameters based on the patient's clinical status. So that's the most recent update that we made in order to accommodate for new order numbers.
Okay, thanks, Alyssa. We have one more question, and while we pose the last question, I'm wondering if we can advance the slide to the evaluation, please. There we go. There's a QR code. If you can please scan that and provide us some feedback, we'd appreciate that. It helps to inform us about future topics. Also at the bottom of the page there in the chat, I've provided the link to where a recorded version of this presentation will be available. And our last question, how do you handle a patient rolling into the ICU from either the ER or the OR on a moderate dosage of a pressor or sedative? So the receiving nurse obviously wouldn't start at the lowest end of the range order, but would continue at the rate running when they receive the patient. How do you manage order compliance around that?
So that's a really common scenario that we see with our patients. And I'm not sure if you noticed that within our order, it says to start, it has a starting dose or continue at current rate. So the nurse then is able to continue at that current rate and titrate up as long as he or she does not exceed the top limit of the range. If it's deemed that there is a need for more medication or higher limit, then the nurse then needs to contact the provider to either change those limits or add another medication or do other interventions to help the patient. So the order compliance is there because we do have an order to continue at current rates. There was a question in regards to protocols as well, and I just wanted to state that we do have a pharmacy protocol that we within nursing, we link to those protocols in our routine care protocols and vice versa. So we have this linking mechanism within our protocols to assist with making the information available to all caregivers. So just wanted to address that since I saw that question.
Thank you. I'd like to thank our speakers for sharing their strategies, barriers, and successes in assuring safe and compliant titration orders. And thank you to our attendees for joining us today for this important topic. That concludes our presentation for today. Again, a copy of the recorded presentation will be posted on our medical education website. Thank you, everyone.
Thank you.
Thank you.
Thank you.